Your introduction through the chat, we'll go ahead and let Bill start with his presentation.
Right. I'm gonna see if I can get this coordinated so that I have the slides on the screen that has the camera. Okay. Up. All right. Can you guys hear me?
Yes.
Let me share my screen now. Screen. Okay. Can you see my title slide?
Yes, sir.
Got you.
Excellent. All right. Well, thank you, Joyce and folks, for inviting me to come give this talk today. I have been part of the Hub team for a little while, but have not been to one of these sessions, and I'm glad to be back. My name is Bill Brooks, and excuse me. I'm an assistant professor over in the College of Public Health, the Department of Biostats and Epidemiology. I'm going to give you guys a brief treatment of epidemiology of opioid use disorder. This is, there's a lot to be said, and so certainly a lot will be left out today, but hopefully it'll be interesting and maybe we'll learn a little bit. All right, so I have no disclosures, financial or otherwise. So starting this discussion around the epi of opioid use disorder, it's important to really sort of lay out the surveillance that we have available to us. We focus in on, when it comes to opioids, we focus in on 4 big buckets, right? So misuse and initiation, the progression to use disorder, and then non-fatal and fatal overdose. As many of you probably already know, our fatal overdose data are the richest. We're able to make the most detailed comparisons using these data because they're based on vital records and fairly comprehensive. With our misuse and use disorder, specifically misuse, we rely on some national community surveys like the National Survey on Drug Use and Health. Use disorder is also captured in some of those surveys, as well as some treatment admissions. But due to the nature of these data and the HIPAA requirements, it can be very difficult to get access to anything even down to the state level with this stuff. So I'm gonna use overdose a lot as a proxy in our discussion today because we basically see our overdoses trend along with our reports of misuse as well as our treatment admissions. All right, so let's start with 2020, the year of the "is this really happening" emoji. We have a new surveillance system that was launched back in January of 2019 that's pretty exciting. It's called OD Map. This is a mobile application that is provided to folks like first responders, law enforcement, EMS, and it has a sort of a EMR setup that they can basically report up, and we can aggregate reports of non-fatal and fatal overdoses. And you can see on the map here what we're at as far as our coverage. It's certainly not comprehensive, but we have 2,600 agencies in 48 states reporting at this point. So I'm going to give you a brief treatment of the report that they released this year. So in the reporting counties, the OD map is indicating a 61% increase in overdose submissions. I certainly don't believe that this constitutes a national increase of 61%. Again, just focusing on the counties that are submitting, and there could be some selection bias there with regard to counties that are seeing a real need for this kind of thing, and so are jumping on board, and so there could be some bias in the data there. But however, that said, we are seeing an increase. There was an analysis done by these folks comparing time from January to March, and then to March to May, which is before lockdown to after lockdown. And in the reporting states, we saw a 17% increase during lockdown. The mechanism behind that increase, I don't think is clear. There may be some folks that are thinking more deeply about this that have some suspicions, and if any of you have any, I'd be glad to hear them after the talk if we have time. We are actually in 2020, we've seen the clusters of overdoses shifting from the urban locations into the suburban and rural areas. And overall, the spike alerts have increased. So in orange there, that's 2020, and in red, that's last year. These spike alerts are what the system releases as a warning so that agencies can be coordinated to respond when we see sort of an out of the norm spike in overdoses in a particular region. So stepping back and looking at misuse overall, we still see that the vast majority of folks are reporting OPR or opioid pain reliever misuse only. In the small green to yellow circle there, that's our pain reliever and heroin use combined, and then our heroin use only. So it's definitely a much smaller portion of the population, but as you'll see, the effects of that population on the overall overdose rates is dramatic. We, of course, know some of the trends here. This is all opioids, so prescribed or otherwise. We have obviously this dramatic increase that we did actually see some dip between 2017 and 2018. Looking here, you can look at the yellow line compared to the orange line, which is males to females, and you can see the dramatic difference in risk of overdose in the male population. As we know, our region, the Appalachian region, and the Southeast in general has been traditionally a hotspot for a lot of these overdose deaths. And so this just sort of reiterates that point here that where you live matters with regard to opioid overdose deaths. So zeroing in on the opioid pain relievers, we have seen the curve sort of flatten in the last 5 to 7 years with a slight dip between 2017 and 18. However, you can see it jumped from 15 to 16 and then back down. So there's a little volatility in those data there. And I certainly would, not put all our eggs in the basket of we're over the hump with the decrease we're seeing here, because we need to look at things at a much longer timeline. We see actually the difference between males and females tighten with opioid pain relievers. And that certainly has something to do, I'm sure, with the accessibility and the lower perceived risk, though that's changed as we've done a lot of media blasts around the risks of opioid pain relievers. So this is a map of the significant differences or changes in overdose death rates from prescription opioids by select states, 2017 to 18. So this is that dip by region between 2017 and 18. And in the peach colored states there, which includes Tennessee, has shown a decrease in that time frame. So, however, some other areas of the country did not. So I'll be making a case later on in the presentation for the sort of the implications of the illicit drug market and its dynamic impact on use disorder and overdose. So unfortunately, Appalachia has a dramatic history around OPRs. We're all pretty familiar with this stuff. Just one data point that really drives it home, I think, is these states in the 5-year period between 99 and 04, those states saw between 102 and 550% increase in poisoning deaths, the 550, of course, being West Virginia. There are certainly some contributing factors that got us there with our what I would refer to as predatory overprescribing on, driven by the manufacturers as well as the physicians in these small communities, concentration of physical labor workers, so a lot of folks with aches and pains, and then a general lack of available health care. In the last decades, we have seen a shift in our demographics for reported regular opioid use. So the green squares or blue squares, depending on if you're colorblind or not, like I am, is the white population, and then the non-white folks are in the hollow circles there. And so we can see just that incredible shift in the demographics. And we know in Appalachia, of course, we're talking about white males, age 30 to 39. And this is historically with the opioid pain relievers, lower educational attainment, experiencing chronic pain and history of substance use. It's considered that our sort of fate with opioid pain relievers in the region was part of a perfect storm, which really started with this surplus of OPRs that led to diversion and abuse. And then a lot of our younger folks, were leaving the region, leaving us, leaving behind folks that may be at higher risk for substance use. And then, unfortunately, it's been theorized that the cohesive nature of our family networks and our social networks kind of facilitated the diversion of OPR. So increasing that those nodes in a network that someone, could as the OPRs could sort of move through within our area. And then, of course, the continued and increasing economic hardships leading to psychological stressors and other things that put people at risk for substance use disorder. Looking at heroin, we have seen increases in heroin use across demographic groups, pretty much across the board. This is an everyone problem. So that's certainly important when it comes to addressing this particular issue. We are now, this is our overdose death rates over time. Looking specifically at the yellow and orange lines, the yellow line is our heroin only overdoses, and the orange line is our heroin with other synthetic narcotics. And the synthetics are overwhelmingly fentanyl and its analogs. So between 90 and 95% of this particular category is fentanyl. So you can see there the kind of threshold tipping point for overdoses attributed to fentanyl adulteration. Again, our heroin overdoses are certainly different across the country. It was really concentrated in a lot of ways in the Northeast and has moved down into the Southeast more and more. I'm hearing anecdotally from folks working in the region that their clients, their patients are reporting an increased supply of heroin recently as of this year. So we'll see how that plays out. Traditionally, it's been fairly expensive and some folks have had a hard time finding it. This is a point of interest that I came across recently as part of a study in 2004 where the researchers tried to establish the ratio of effective dose to lethal dose. And they did this across a lot of different substances, and I can send out the citation for this. What this is trying to tell us here is that the ratio from the amount of alcohol you would have to drink to have psychoactive effects, that step between that effective dose to lethal dose is 1 to 10. So 10 times what you would take to experience the effects of alcohol would theoretically kill you. Cocaine is 1 to 15, methamphetamine is 1 to 10, and heroin is 1 to 6. And what that says is that, as our use disorders shift, that I would argue they're shifting because of, prevention methods with OPRs and as well as the illicit drug market changes and what's becoming available. As those use disorders shift to heroin, our risk of overdose increases, and we're seeing that because that window for an individual to get high but not overdose is very thin when it comes to heroin as opposed to some other substances. So we have experienced what some are referring to as 3 waves of the rise in opioid overdose deaths, starting with opioid pain relievers, then heroin, and now other synthetics, specifically fentanyl. And so some of us have probably seen this picture on the side. Here is a lethal dose of heroin compared to a lethal dose of fentanyl, which is 50 to 100 times stronger than heroin. So when it comes to fentanyl, I've been thinking about this a lot lately, and I'm interested or excited to kind of roll this idea out because I've not really presented it to anyone. I'm starting to think of fentanyl in terms of an infectious disease epi model, right? So we have the host, the environment, and the agent. And when it comes to fentanyl use disorder as our sort of disease outcome, this interplay between the person who is at risk for exposure with the variable drug market, and that sort of driving the fentanyl adulteration. I mean, this is sort of a little bit past the idea or the behavioral model of use, right? So we can, if we accept that there's use and then that puts them at risk for encountering this particular substance, then it's more of sort of how that substance is moving through the population and specifically the drug market to infect or cause the outcome that we're interested in or expecting. And what this does, as sort of fentanyl kind of bleeds into the market, we have an increase in opioid use disorder severity by way of increased tolerance and drug seeking. So as folks experience the high of fentanyl and the way that it works, it has a much shorter half-life in the body, and so it requires sort of more frequent administrations of dose, and so that opioid use disorder severity increases and ultimately leads to increased mortality. So we have some geographic variation, and again, this would, I would just go back to my point about the drug market and thinking about fentanyl as an agent of disease in the population. Tennessee is in pink there, showing an increase between 2017 and 18, as well as South Carolina. But we have, some folks were stable and there was some decreases. It looks like in the upper north or Midwest, some dramatic, or actually their data was not included there. So I'll just move on from that. Another point that I know that I find myself saying fentanyl a lot in these presentations, but I'm just going to keep saying it. When we talk about fentanyl, there's some things that I don't think we really talk about in the context of the epidemiology around opioid use disorder and where we're at today. It's important to think about production and sort of where we're getting this substance from. And so it is synthetic, it's made in labs, it's very attractive to drug cartels and other organizations, international organizations engaged in the drug trade, because they don't have to find or hide or dedicate, large swaths of land to growing, natural substances like opium or poppies for opium, for heroin and so forth. It can be made in a lab very easily. The same is true for methamphetamine, and that's why we're seeing that increasing. There are two methods of synthesis for making fentanyl. 94% of what's being seized is the more complex synthesis of this product, meaning that it's trained chemists that are creating it. So this is not a backyard project like we see as part of the methamphetamine that we see. We see a lot of the current crystal methamphetamine coming from Mexico. But the point being here is that these are well-funded individuals and organizations that are producing the fentanyl that's found in the US today. There's two sources, Mexico and China. Mexico is obviously transported over the southern border, and it's coming in from China via the mail. China just has at this point, a lot of production labs, and there's not a ton of oversight on those labs. And so folks are able to make precursors that are then used to make fentanyl, and it's a whole thing that winds up with fentanyl in the hands of dealers in the US. The issue that is, I think, of the most importance in this discussion is the variance in purity between the Mexican and the Chinese sourced fentanyl. So imagine, if you will, if you're a user or someone who uses drugs and you don't know if fentanyl is in your substance or not. You also don't know if it's in there, how much is in there. And then add another layer now, you don't know if how pure that fentanyl is. So you can see the levels of uncertainty that are making this whole scenario incredibly dangerous. And and fentanyl represents kind of an evolution in our street level drug trade, because prior to fentanyl, we didn't really see psychoactive substances being cost effective as cutting agents for the drugs that are being sold. So now you can take a substance that's very cheap, you can increase your supply for sale and have it maintain its potency. So looking at purity, stay with me here. So we have quite a bit of difference in drug purity overall in the United States. So east of the Mississippi, we have much lower purity in our drugs across the board. And when we look at the effects of that purity, if we go on the x-axis here from left to right, less pure to more pure, we can see that our overdose rates actually decrease. So there's some effect of the purity level on our overdose rates. And we can pretty much overlay this map of overdose onto this map of purity in the United States. And one thing I'll say that I know from the research is that there is a pretty distinct correlation between the purity level of heroin and the prevalence of fentanyl found in the supply, right? So all of that I've said about fentanyl is sort of at play here when we look at purity of our substances across the country. We are currently in a fourth wave of opioid overdose deaths, again, sort of driven by fentanyl, but also by an increased quality of methamphetamine in the country, sourced from Mexico. The cartels down there are very savvy, very responsive, and almost prescient in their looking ahead at what the market is going to be doing legally and otherwise. And so we are seeing fentanyl as an adulterant in basically anything that it can mimic visually. This is some seizure data between 2014 and 2017 in gray there. That's fentanyl alone. So you can see the seizures increasing. So its presence in the market is increasing. And in blue there, that's fentanyl and heroin. Down there at the bottom there on the right-hand side, you see fentanyl and methamphetamine peaking out. And I think anyone that is working with anyone who is actively using in the region will tell you that methamphetamine is a huge problem and is getting bigger. Some anecdotal data from clients of a syringe service program in the region here. These are the substances that folks are reporting as drugs of choice for injection. The bullet there for fentanyl, it's important to note, is that's fentanyl alone. We can't give away fentanyl test strips for folks to test their other substances for the presence of fentanyl. They don't want it because there's no point. It's in everything, is what folks are saying. All right, so wrapping up, opioids are still killing thousands per year. There's some unclear effect of the sort of all the things that have happened this year on our overdoses as reported by the OD MAP system. We have new users of OPRs and heroin and fentanyl each year. So it's still, we're inducting folks into this issue. So misuse is certainly more prevalent than heroin. So OPR misuse, that is more prevalent than heroin. However, heroin mortality rates are comparable. So that really speaks to the sort of lethality of the illicit heroin market and what's available. Heroin use is a problem across demographics. And yes, it is. Fentanyl is the deadliest substance in the illicit market found in anything it can mimic today. That's it. Thank you.
Great. Thank you, Bill. That was awesome. There were some really interesting graphs and data and charts I've not seen before. So thank you for sharing. Very much so. While you guys are conjuring up your questions and thoughts you want to share with Bill, I'm going to ask a couple of joiners to unmute and introduce. Debbie Hillen, if you can unmute and introduce, please.
Good. Is it morning? I don't know. Morning or afternoon. Hi, this is Debbie Hillen with Buffalo Valley.
Great, it's nice to have you with us, Debbie. And Ryan Toole, can you unmute and introduce, please?
Yeah, hi everyone. My name is Ryan Toole. I'm a clinical pharmacist at Johnson City Family Medicine and a hub team member.
Great, thank you, Ryan. It's nice to have you with us as well. What questions do you guys have for Bill?
I said it all. I said it
No, you
all.
knocked it out of the park, Bill. There's nothing else to say. So we're digesting it still.
So I was curious about that list, the second to last slide you had about the different drugs that people are opting to inject, and that everything is laced with fentanyl, like even the Ativan and like the more the medications.
Well, so the report that people are saying that it's in everything, and then that some of that is maybe a little hyperbole, right? But the point is people don't want these test strips because they feel like there's no point. They already know it's all in there. I would say as far as medications, people are pressing fentanyl into pills of all sorts. Yeah, so I believe it's, I want to say Xanax. If someone is trying to sell you Xanax on the street, it's almost certainly not Xanax, is what I've been told. And you can buy a pill press from Amazon for, I don't know, probably nothing, $40. Yeah. It's so cheap. If you can get a hold of it, it can be transported, like effective cell doses, just like this much is enough for like a city, right? So it can be transported very cheaply and it's very cheap to get. So if you can get a hold of it, you can, get it. It's a lot harder to find Xanax than it is fentanyl at this point.
All right. Thank you again, Bill. It was quite enlightening. Always enjoy your presentations. Oh, yeah, Angela, go ahead.
Yeah. Hi there, Dr. Brooks.
Hello, Angela.
Long time no see.
I know.
Yesterday. This is a lot of new stuff for me. I mean, we've been doing presentations like this in our center for a while, but there's a lot of new data here. And I guess I'm just curious how you access some of the DEA data, maybe specific to the purity, and if that's something that the public can obtain, or if that's just something that you had some special magic and were able to gain access to.
I'm so glad you asked that question because I was very intentional actually I have hyperlinks in all of the figures. And so if you're able to, I think somebody said that the presentation is already on the website. Yeah, so if you go to the presentation on the website and you click those figures, it will take you to the source of those figures. So the website and all that stuff. The DEA, I'll tell you what, I think it's the 2019 DEA report is fascinating. Some of the most in-depth information is in that report, and feel how you will about interdiction and its impact on overdoses, but they seem to really have their stuff together when it comes to data collection and reporting. So I would recommend that. And there should be, if any of those links are broken, please let me know. I'll definitely get everyone access to that stuff. It's all publicly available.
Oh, cool. All right. Thanks so much.
Welcome.
We're actually going to cruise into